Having just shared our journey with you this morning, I'm not going to harass you with any more slides. So really just to continue on the theme of how do we support adoption of new models of care? How do we get the change really owned by the professional community so that it's the best of the top down, creating the conditions for improvement and quality, as well as the bottom up led by the professionals. And I suppose my experience in Scotland has really been around that you have to build the capability of a clinical leadership community. And that's a multi-professional clinical leadership community. It's not just about the doctors, although it is absolutely fair to say that the public profile of the medical community is very high. So if you are really serious about some service change in your local community that might involve, dare I say, closing a ward or closing a community hospital, if you're reinvesting in primary care services, that has to be doctor-led. And I speak with personal experience. If I can show you the scars of public sessions in community halls and sports centres where we've been describing that change and why we're changing, making the case for change persuasively with the public is something that you need strong clinical leadership for. In Scotland, we've invested in a programme called Delivering the Future, which is now in its 11th year. And each year we build a new cohort of multi-professional clinical leaders who get immersed in both leadership and quality improvement training and development, and then go back to, they're doing that while they're still doing their day jobs, and then they are used by their district health boards, by their primary care teams or their hospital services to lead the change from the front and to be powerful change agents, change champions, ambassadors for change. So I suppose I would say it's all about leadership. It's all about leadership and it's all about relationships.
Thank you. Janice.
Kia ora tātou. I am going to harass you, I'm afraid, with just a few slides. So when thinking about this topic, it occurred to me that I probably should just talk about how I think about performance reviews of my staff, having just been through performance review time at the end of June, early July, and how we kind of think about performance as an organisation. But I'm not going to do that. You'll be relieved to know. But in thinking about that, I thought I'd just use an acronym about when I think about performance. And I think, as Anne said in her presentation this morning, that the purpose of our work, why we're here, vision, mission, our job, our role is absolutely crucial to everything. And in thinking about performance, expectations, or what drives us, which are both external and internal issues, and above all, trust, and Anne mentioned trust as well, trust which brings commitment. So I am going to talk about sport a bit, or use a sporting analogy. And when I was in England at a conference in London in April, I got to visit West Ham United Stadium. They have a very strong focus on quality improvement, as all sports do. So sport is very focused on performance and how to improve performance. And we know that from our own obsession with sport in this country and our success of that. So when we think about purpose, of course, if you're a sporting team, it's about winning every game. It's about being the best, and if you're owned, as all of many of the teams are privately owned now internationally, it's about giving a return on investment to that owner, and indeed to the public and the fans. And I guess you could say it's about giving value. That's the purpose. And for us as clinicians, it is to respond as best as possible to every health need of every person and their family and to the community and the population, so much broader. And I guess it's also about giving value or giving a return on investment to the funder or the payer or to the business that we're in. In terms of expectations or drivers, if you're in a sports team, there are a whole lot of intrinsic motivators. It's about just doing the job, professionalism, doing the right thing. That's true for us as well. It may be about seeing improvement or opportunities for development or just getting out of bed excited and full of joy about doing the work. So, it's about successfully passing the ball or scoring the goals or the tries. It's about being physically fit. Or in health, of course, it's about just the extraordinary privilege that we have as clinicians about talking with people about their lives and their families and the things that are important to them, seeing the children that are born in your practice grow up to be old people, and helping people manage their health, helping people die. External motivators are also very evident. The financial rewards, the incentives that are there, and measurement, looking at measures and the transparencies of those measures are often considered to be an external motivator. Feedback from people, feedback from the public, the opinion of our peers is important, and targets that are set. Of course, targets are set in teams, sporting teams all the time, but funders and owners can set those targets and can managers. There are certainly bonuses for winning, and we know that in our sports teams, and what our peers think of us in the team is very important, what the coach thinks and what happens when targets aren't met. And we all know that in health there are financial incentives too to deliver on such external motivators, whether that be for government or just sustaining the practice business, or whether that's responding to complaints, or whether that's about accreditation. So I don't know if Helen Bevan showed you this slide, but I pinched this from her, but intrinsic motivators are really about the heart of things, getting up out of bed excited every morning, and extrinsic motivation can be linked to rewards and punishment, to both. But to go back to West Ham United Stadium, like all sports teams now, they have a very complex system of measurement and targets for each player and for the team, and they have cameras all around the ground that focus on individual players and how they actually go in their game, and each individual player has certain things they have to achieve within so many games. So, many of you will probably know more about sport than I do, to be honest, but sport is actually quite a complex and measured full system than it used to be when, I was at school and we just played sport for the hell of it. And I'm talking really about teams and not about individual sport, although I really do enjoy watching tennis and individual performance. But actually this is really about team work, and we know that health is a team sport. Health is a team delivery system. And although measurement and transparency are said to be external motivators, they actually are fundamental to understanding performance. And the trick is, or the important thing, is how to make measurement intrinsic, how to make you all of us excited every day about jumping out of bed because we're going to see the measures of what we do, the measurement about our patients, about our service, about our practice, and how that informs us about how to do a better job and how to make us feel better about our work, how it helps us with the joy of it. But nothing ever happens without trust. And so do players actually trust their coach? They might have all these measures and intrinsic and extrinsic motivators, but without trust, the whole thing doesn't actually work. So do they trust their coach? Do they trust their team players, their members? Do they trust their owner or funders? And trust is so important because it actually is the kind of essence that brings a commitment to all of this. Now, there's quite a lot of work done, and Helen might have shared with you this slide, but this is from the Health Foundation Constructive Comfort Accelerating Change in the NHS report, where there are 3 types of kind of mechanisms for changing performance. And you know, everyone's quite familiar with the PROD one. That's the targets that are set, the measures that are externally set, the management, the payment for performance. And the type 2, which is the intrinsic one, the ones that is about relying on people to make the change themselves, to be excited, to be working together, to want to do it. And then the type 3, of course, is the professionalism and the accreditation and the clinical practice. Now, this report actually says that the type 1, the PROD mechanism, only ever accounts for 10% of performance improvement. So the most important one, I think, is type 2, but also type 3 is equally important. So drama. Well, you know, life is not without drama, quite frankly, and you can't get improving performance without drama. Sometimes drama is good, and sometimes it's bad, and sometimes it's good and bad, you know? That's kind of how things are. Sometimes it's important to have a bit of drama because it provides the zest and energy to get some schism in the team or in the system or in the individual, and to think about what needs to be improved and to change paradigms. So it's the relationship, really, between the intrinsic factors that make us jump out of bed excited and the external or extrinsic factors that provide the motivation. And, you know, drama occurs because there are different values in every system. And this is a competing values framework that was put together by Quinn and Cameron some years ago from the University of Michigan. And if you Google it, you'll just find it on Google very easily. And we, as doctors, all come from more of a clan-based value system. Although, of course, if we're running our own business, there's a bit of market going on and a bit of competition and achievement in that sense. And we all kind of think that government is about hierarchy. So, you know, the structure and the coordination and the efficiency and the control is a different kind of value. And of course, there is the entrepreneurial groups as well, looking at how to do things differently and take risks. And when we get drama, it's because we often get a clash of these values. So very quickly, another paradigm. What we really need is a symphony orchestra that actually melds together all of these things in a way that makes performance work and we get improvement. Thank you.
Thank you, Janice. Some interesting things to think about there for a New Zealand society so keen on sport, and the sporting analogy is quite apt, I'm sure. Graeme Osborne, he's the chair of the National IT Board.
Thank you, and thanks for giving me a chance to come and talk with you today. I found myself really enjoying Janice's presentation, and one of the themes I want to pick up from it is that health and changes we want to make to health has got to be a team game. And I want to use the patient portal rollout that we're partway through as an example, and at the end of the presentation I will give you an idea of where we're up to in terms of statistics. But I think that's the theme I want to draw out when we talk about change and performance, is the difference between the what's and the how's. And so we love to focus on what we're doing and measuring things and numbers and statistics. But I can assure you the reason the Patient Portal Initiative and other initiatives that are successful absolutely focus on the how's, how we go about the change. And I know in the audience today there's a number of you that have been involved in national health IT initiatives, and specifically there's 2 or 3 of you who are part of our group of 7 e-health ambassadors who were brought together as general practitioners who had already seen the benefits of introducing patient portals to some of their patients, not all their patients. And they came together 18 months ago, and I don't think they mind me saying, but we put on a little bit of a presentation for them with the Minister in Parliament, and we made them feel good, and we put a little bit of travel budget in their way, but other than that, we didn't do much else. And I just want to acknowledge the eHealth ambassadors. They've been absolutely outstanding taking the message of the benefits of patient portals, because the benefits are in 3 areas. They benefit the consumer because the consumer is empowered by looking at their information, not just their information today, but looking at the historic nature of their information as well. The clinicians are empowered together. So in fact, we have Sapere have done some research that shows us that nurse time, up to 30% of nurse time is given back by taking away the mundane activities that are related to telephone calls and other activities and practices. And we're starting to see that now in real time, and not just with Sapere doing the research, but the actual rollout is proving that as well. So if we just think about the how so much more, and it's the point that was made earlier about respect and about trust, who are the stakeholders, who need to be in the room, and who do we need to bring through in the conversation? How do we empower the right leaders to take the change back into their communities? And how will we measure that we've made a difference? And all of those are key aspects of performance. So I indicated that I'd give you a heads up and an update on where we are with the patient portal rollout. As at the end of June, I'm very excited to be able to say that 75,000 New Zealanders are accessing their health information online, and we have 181 practices out of 1,080 who are offering that service. But probably what's more exciting is those 181 practices represent 30% of the adult population in New Zealand. So if there are New Zealanders out there at the moment, almost a third of them, if the GP is happy for them to have access to their notes, they can have that offer and accept that and take that offer up. Equally exciting is the ambassadors are still meeting. Now, again, I mentioned earlier to you that we brought them together in an event in Wellington, in Parliament, and hopefully they still remember that event. But we had a phone call with them just a week ago. And I'll be frank, I thought they might have had enough. You know, they've sort of put a lot of energy in, they've supported their colleagues. And yet, the really exciting thing for me as an orchestrator of this change is the energy, and we had 5 of them on that call, the energy they were still showing about the benefits, the learnings they were still finding, and yet they've been in this game for 3 or 4 years, and the exciting opportunities that were starting to grow. So I'll finish by saying measuring performance is as much about the people and the change and the how as it is about what is achieved. And it's only a stepping stone, as the saying, as it says on the slide. We keep measuring performance of today, but we've got to have our eye to the future. How far do we really want to go? So I'll leave a thought with you. Do you think patient portals are the end or just a stepping stone to some other future? Thank you.
Considerable food for thought. Now, Graeme, your portal ambassadors, are there any here?
Well, I saw Sue Wells was
yes,
here, and
Three.
Awesome.
Great. You might get inundated with people coming to talk to you, including me, possibly. So our next speaker is Cathy O'Malley, who needs no introduction, I'm sure. Deputy Director General, looks after primary care from a ministry point of view. So, Cathy.
Thank you. I'm not sure I try and look after primary care from the ministry point of view. I think it's much more important that it's taken from a whole range of point of views, not the least of which is most of yours in the audience. For me, inspiring performance starts and finishes here, really. This is about all of us in the first place as individuals, and unless we are motivated as individuals, unless we love what we do, unless we really enjoy doing great work and we seek out how we're going to achieve that, then we're not going to go much further, no matter what we do from the centre, certainly no matter what I do from the Ministry of Health's point of view. I started my career in health probably as a consumer, other than when I was born, when I was a student and I fell off a donkey and I was admitted to hospital with a suspected hip fracture. Most of my early career in health was spent managing general practice, and I learnt most of what I know from the GPs in that practice that I spent several years in. The middle part of my health career was spent managing primary health organisations for quite a number of years, and now in the ministry I have a whole different perspective on what my contribution might be and what it takes to make a difference. I wanted, like Janice, to pick a little bit up from where Helen Bevan was talking yesterday, and this kind of thought about prod and proactive support and people-focused intervention. And when we were talking about that yesterday, I think a lot of the people in the audience and some of what Helen was saying kind of interpreted this as a system versus profession, or a central agency versus the GPs, or that kind of dynamic going on. I suppose I have an absolute understanding of what that's all about, being on one side of it, but I also think that this kind of logic around what we're doing here has a whole lot of other dimensions across the spectrum. If we thought about this from a patient perspective, when we're looking at our health strategy at the moment, one of the things that we're really trying to think hard about is how do we excite the population? How do we engender some intrinsic motivation in people to look after themselves more? Because it's obviously the case that the health system and probably the patronising kind of response of a health system is not going to take us where we need to go as the burdens of ageing populations and chronic disease and stuff hit us more and more. So how do we prod patients? How do we incentivise patients from the outside? How do we try and tap into the intrinsic motivation of patients to look after themselves more? How do we do that at a GP level? What does this mean for you as individual general practitioners? When do you feel prodded? How do you feel supported? And what is it about the profession that needs to get in on the act here? And then you can bring it up to your practice level. How much of this is going on in all three levels in your practice? I'm sure as employers and as business owners, you do a bit of prodding of your staff. We have employment contracts, we have employment agreements, we have expectations about how people behave. I'm sure there's a certain amount of support that goes on within your practice setting, and I'm sure that you also focus on the professional development of your staff. And then we could keep going on up the chain in PHOs and DHBs, and from my own perspective, obviously, in the role that I play at the moment, what does all this mean for us as a ministry? So I suppose what I'm saying is our collective challenge at all these different levels is about balance. It's about how that works in our own settings, both from an individual perspective and how we try and make sure that we love our work and we're doing great work. Whether the specific interventions and the balance between them in our own setting, whichever level you're looking at it, are effective enough. Because even if we have the right balance, if any one of the interventions is weak, then we won't go anywhere. Most of all, how do we successfully at a system level, if it's so interesting in getting this right at so many different levels in the system, how on earth are we going to have a shared view across the whole system? One of the challenges of the health strategy refresh is trying to do exactly that, and certainly the ministry has tried to set up a process in recent months where many of you and all sorts of other people across the system and NGOs and in the consumer organisations have been engaged in trying to establish what is the shared view of where we want to go and how we need to get there. How do we reach beyond the rhetoric? We've had lots of checklists over the conference, we have lots of theoretical papers produced, but how are we actually going to get beyond the rhetoric and make it happen? So, you know, we have these kinds of things. It's in all of the literature about commitment, about committed and respectful and respected leadership, about culture, about management practice in the schools to do the job, about data and analytics and all this stuff that we need to make sure that we've got. And collectively, again, at all our levels, in your practice, in your PHO and your DHB and us for the ministry, we all need to look at what our role is in making sure that this is consistently the case. But I'm also really interested in how this works in terms of the relationship between the key players, the relationship between the layers in the sector, and how we move that forward. Because it does kind of feel, I'm sure for you, and it certainly feels for me, like sometimes it's 2 steps forward and 1 step back. I think we are making some progress in terms of the dialogue that's going on between the different parts of the funder and the policy makers, part of the sector, and people like you in the audience. But there is a requirement in amongst all of this for accountability and commitment. There's a shared vision that we need to have. It needs to absolutely be reality checked by people like you who do the work every day at the coalface. We almost certainly need a longer term investment approach. An annual planning cycle is not helpful in any of this. And every part of the sector needs to have a sense of value in what we're actually doing. So the New Zealand Health Strategy Refresh is an opportunity. It's an opportunity for a shared direction. It could be a disaster if we don't have one. It's an opportunity for achieving the right balance and the improvement approaches. How strong do the prods have to be? Certainly if you're Minister of Finance and you're putting billions of dollars into health, it's not surprising he wants to know what he's getting for his money. He wants some level of measurement. He is going to use some prod. But how strong do those prods need to be, and how much can he trust the intrinsic motivation of the sector? How strong is the intrinsic motivation in the general practice team? How strong is the intrinsic motivation in each one of you to do great work and to love what you do? Will the enablers in terms of support be consistently there across the country? All I can say is we have had a process of co-design of the strategy so far. It's gone slightly internal in the Ministry of Health while we write the next draft. It will come out for consultation sometime quite soon. All I can ask is get involved. This could be great if we crack this issue around shared vision, around the right balance between prod and support. But it will only happen if you get involved. And why should you do that? Because your work takes up a lot of your time. My experience of the health system has been people really do want to do great work. You are highly motivated. You're great people to work with. But we really need to make a difference over the next few months in the health strategy, or we'll suffer the consequences for at least the next decade. Thank you.
Thank you, Cathy. Some challenges there for us. And our fifth speaker is Ross Lawrenson, who's Professor of General Practice and General Practitioner.
Thank you, Mark. Yes, I want to take a slightly different view of this. These are slides that I've used a lot and I like to use. The top slide is a relationship between the number of specialists that you have in your health system and the costs of your system. So you can see the more specialists you have, the more expensive your health system. And the bottom slide is the number or the quality score, which was around things like measuring blood pressure or breast screening and the quality of the health services being provided. And you can see the more specialists you have, the lower your score for quality. This is American data. On the other hand, if you look at the alternative, if you look at the number of GPs, which is the top slide, against cost, the more GPs you have in the system, the more your costs go down. And on the bottom slide, you can see the more GPs you have, the greater your quality of care. That's true as well in the UK. This is the number of patients per GP and the QOF score, and there's a relationship between the bigger, the practices with more GPs per patient have a better QOF score. And this was a paper from the Lancet. It's not just about process issues. In Indonesia, they decided that they were going to increase their hospital budget by 20% and decrease their primary care budget by 20%. And that resulted in an increase in perinatal mortality in 24 out of 28 of their provinces. So the number of GPs and primary care workers improves or can decrease your quality of care. So what have we done in the New Zealand health system? You can see here that over the time of the primary healthcare strategy, we increased specialists by 53%, and we increased GPs by 14%, which was just 2% above the population increase. And we wonder why we're struggling with the costs in the health service. It's not only the numbers of GPs. This is some work that Rawiri Keenan did with Midlands Health Network, where he's looking at the ratio of nurses to general practitioners, and we showed that, if you had more practice nurses than GPs, you had a 30% greater retention in the diabetes program. So we need to think not only about the size of our primary care teams, but also around the makeup of those teams. So just very simply, I think that actually having more performance targets for the current teams is not the way forward. I would like to see in the new primary health strategy that in the next 10 years we'll see a 50% increase in GPs and not an increase in the specialist workforce. And I also think that we need to think about where we're investing in our infrastructure. In the Midland region, we've invested $850 million in new hospitals, but apart from Tokoroa and Tikawiti, where the DHBs have very wisely, I think, invested in our infrastructure, we've had no real public support for the infrastructure where we work. So I think if you want to increase quality within the health service without drama, the thing to do is concentrate on our workforce and also about our resources that we have. Thank you.
Thank you, Ross. Now, we are getting close to time, but I am going to take a few questions before we wrap it up. For those who are asking questions, I'd ask that you come and find a microphone to ask.
This is not a question, just a comment. I think one of the things that all people that are involved in changing have to bear in mind is that in quite a number of areas of the country, there's been considerable stress on the workforce, combined with the need for change, and you've got to be really careful about the management of risk of burnout of those that are working at the coalface. And that is something that at another conference I've been to, they talked about compassion fatigue. That is a very real entity that we have to factor into things as well. So all these things take time.
Okay, other questions? Thank you.
Just Jethro Leroy, GP in Tauranga. Question to you, Graeme. I just have some concerns. I'm all for patient portals and developing things, but a lot of my patients don't have computers and don't have access to that, and I just wonder whether it's going to increase disparities and inequities with certainly some of my population using, or not having access to technology.
Yeah, thanks for that question. And the National Health IT Board's very mindful of exactly that situation. I think there's a couple of ways to think about it. Specifically with patient portals, we're seeing those practices that are getting up to 20% of their patients using the portals. There's a reduction in telephone calls and frontline support services by up to 10%. And what that does is it frees up that resource to work with those parts of the community that maybe don't have the electronic connection. So it's about making sure you can reuse your capabilities and your support and your nursing and other services where they are going to be most valued rather than in administration. I think the other thing is that the government overall is working incredibly hard to focus on some of those communities, and I'm aware, in fact I was in the public library in Wellington, there are free internet access sites in public libraries. Now straight away people are going to say, well hang on, that's not that private, but I guess my observation is you'll be surprised that through digital natives, through kids, through schooling, there's a huge upswing where parents and others are starting to get access, maybe not to their own owned equipment, but to equipment that they can access the internet. Thank you.
Any last questions? One last question. No, Tony.
Thanks very much. Very interesting presentations. Just really more a comment in that it's, I think, very difficult in general practice to get good performance if we're being prodded to achieve targets which we believe are not useful in improving the quality of care to some of our patients. I was very impressed with Anne's presentation, which was seeming to get away from those inappropriate targets, and I hope we're continuing to go in that direction.
So, clearly some resonance with that. We are now out of time, so I'd like to just thank our speakers. Just in wrapping up, I think what I took from this was the common factor was talked about inspiration and passion, and actually they made the comment that what we need to do is take those extrinsic targets and make them intrinsic, things that we want to do, and that's I think our challenge. So thank you, and I'd like to thank our speakers once again.